is common in these women. They often have coarctation of the aorta. Now, many people have coarctation of the aorta and they don't have Turner's, but you do often see coarctation in Turner's. They often have renal abnormalities. One of the great examples I like to mention are the horseshoe kidneys, because, well, horseshoe kidneys is one of the abnormalities you may see in Turner syndrome. So they show you one of those kidneys, be thinking Turner's. These women have an increased risk of Hashimoto's thyroiditis, increased risk for osteoporosis. Well, that makes sense because they don't have estrogen to help build up their bones. They have an increased risk for diabetes, mostly type 1, but yeah, and for type 2 as well, but mostly type 1. So you screen these women fairly frequently, and they have a risk for aortic dissection, which sort of makes sense with all the aorta stuff they're having, the problems they're having. So how do you treat Turner's? Ideally, you start the person on exogenous estrogens. When would you start it? Well, ideally when it would normally start being present in her if she didn't have Turner syndrome. So you want to start estrogens at about the time that you'd expect her to start puberty. And later on, then you could start adding progesterone periodically to get the uterine lining to be lost, because you don't want to increase her risk of uterine cancer. So the estrogen is going to help bone density, and the progesterone is going to induce demences and protect the endometrium. You also want to get an echocardiography every 3 to 5 years, because remember, she has a high risk of aortic dissection. Wouldn't it be better to catch it early rather than too late? So the echo can do that every few years. Check thyroid function. Well, she has a risk of Hashimoto's, which would be end up being hypothyroid. So check thyroid function. This is easy enough to do. TSH, free T4, simple, easy, inexpensive. Check those labs every year. And as I said, if you find a Y chromosome, send her for surgery. Amenorrhea, like everything else in endocrine, can be primary or secondary. Secondary is sort of easy because it means she's had menses before and now it's stopped. Usually it has to be stopped for 3 months or so before you can say, secondary amenorrhea. Primary amenorrhea is a little bit more difficult to diagnose. In the adult endocrinology world, we don't have to worry about it, but sometimes they'll ask you some questions about adolescence. So this could pop up in the exam perhaps, but primary amenorrhea would be no history of any menses by the time she's 16. Okay, so she should have had menses by 16. If not, then this is primary amenorrhea. Or no secondary sex characteristics by age 14. How do you evaluate amenorrhea? Well, first, do a pregnancy test. Absolutely. No, I'm not going to do any jokes about that. So, pregnancy test. Also, check prolactin and a TSH. Check the ovarian axis. In other words, get FSH and LH. If the ovaries have failed, then LH and FSH should be elevated. But if LH and FSH are low or inappropriately normal, then you're thinking about the problem being upstairs, CNS or pituitary dysfunction or something. Because if the woman is not ovulating, if her estrogen levels, for instance, are low, then the pituitary should be responding by making lots and lots of this LH and FSH, and if she's not, then there's a problem upstairs.